Good afternoon. I would like to thank MSD for making this lecture possible. This is mainly derived from the module prepared and presented by Dr. Grace Sarbosa, Professor and Chair, Department of Anesthesiology of UP College of Medicine, Philippine General Hospital. She is also the chairman of the Philippine Board of Anesthesiology. We will be presenting our intubations from March 14, 2020 to February 2022. Then the physiologic changes affecting those who had COVID and those who had quarantine and isolation because of the pandemic, and what we are doing to prepare for the new emerging cohort of patients whom we will meet in the operating room and non-operating room anesthetizing locations. Where are we now in the course of the pandemic? Let us look back at the last 2 years of the pandemic, our intubations outside of our usual anesthetizing locations, COVID in blue and non-COVID in orange. Before the pandemic, we do not monitor this. But because of the risk it entails, with a sharp increase of cases, and our scope became whole hospital, we monitored the PPEs worn, the locations, the reasons for intubations, extubations, reintubations. The wave is similar to the COVID surge in the National Capital Region in 2020 and in 2021, such that if there is surge in NCR, we anticipate our intubation to increase as well. But in January 2022, our intubations did not increase, even if there was a surge. This is multifactorial. Our ER counterparts are already intubating in ER. Vaccines have been inoculated to vast majority, decreasing critical cases, and the oral antivirals given as outpatients in the emergency rooms. How about our operations and procedures requiring anesthesia? Predicted in 2020 that surgeries will rise dramatically because of those that were postponed. But just as these start to increase, another surge happened in 2021 March, then Delta surge. COVID cases gradually decreased with the filing of candidacies for elections of 2022. And when laymen thought in December that the next surge will be after elections, Omicron came. It was only in April this year that RT-PCR is no longer required for procedures. Anesthetic cases are steadily increasing. Moving and preparing for endemicity, we use all our armamentarium that we have learned to improve our interaction with patients who are anxious as they go back to hospitals after months of quarantine. Because of the increased hospital influx of patients taking advantage of the low COVID census, we are now facing patients who have had COVID and patients who have been sedentary because of quarantine restrictions, now numbering millions with multiple organ systems affected. First, let us review the different acronyms describing patients who have had COVID. Centers for Disease Control and Prevention defines post-COVID conditions as an umbrella term encompassing the variety of health consequences that may be present 4 or more weeks following infection, which include pulmonary symptoms, mood changes or cognitive impairment, and generally impaired daily function. Several studies show that diagnosis COVID recovered does not mean that patients will be symptom-free even if already discharged from hospital. By 7 months, many patients have not yet recovered mainly from systemic and neurological cognitive symptoms, and many have not returned to previous levels of work and continue to experience significant symptom burden. They have plotted the symptoms by organ systems from the onset of illness symptoms up to 28 weeks. And they found a host of several symptoms from brain fog and memory issues to headache and insomnia. with the highest probability of fatigue and post-exertional malaise. But other symptoms are not far behind, including cardiovascular, and another high probability are pulmonary symptoms. Why is this emerging global crisis of concern for us anesthesiologists? Because 31 to 69% of COVID-19 patients meet the CDC definition of long-haul COVID, and this translates to millions who will have surgeries or procedures under anesthesia care. These patients will have symptoms during stress and other triggers. This may necessitate additional preoperative testing or delaying elective non-cardiac surgeries. Less dramatic effect than COVID-19 infection, months of isolation will have a deconditioning effect on millions of people through cardiovascular disease, diabetes mellitus, and cancer. National databases indicate that patients delay consultation and avoid emergency departments because of fear of contracting SARS-CoV-2 or because they do not want to burden health systems. As Dr. Herbosa says, the impact of the pandemic on perioperative care now needs to be considered. It affected many surgical patients. This means anesthesiologists will face a more complex patient cohort in years to come. How do we prepare for this? We address modifiable risk factors. This starts when we see patients in OPD or Paris clinic even 2 weeks before the scheduled surgery. We optimize patients through education on exercise and strengthening, increasing protein intake, supplementation, stress reduction. Related to this, we have a new form to be used in our pre-anesthesia clinics, documenting the instructions and education we gave our patients. We try to have a checklist at the clinic, which includes frailty assessment for those who are 65 years old and above, and also for those who required hospitalization for COVID infection. Currently, there is no standardized frailty assessment tool used. The Edmonton Frailty Scale, validated for use by non-geriatricians, is a candidate for this role. The little data evaluating its use in the Asian populations make this a possible topic for any of our research. The Singapore General Hospital made study on this to assess if EFS can be implemented as a standard tool in the outpatient preoperative clinic. This was found to be a significant predictor of postoperative morbidity. Aside from frailty assessment, we can use biomarkers to predict which patients will have long-haul COVID. Predictors of sustained disease have been identified, and some are treatable only if these have been initiated during the COVID hospitalization. Preoperative laboratory testing will also have to be adjusted by the changes brought by the pandemic. The PGH Preoperative Assessment Teaching and Education Center, or PATEC, with its Department of Anesthesiology, have an ongoing discussion on this based on several journals. The tests are based if the patient's history of COVID is symptomatic or asymptomatic, and depends on if the surgery is minor, intermediate, or major. If we deem the patient's surgery should be delayed, discussion with all stakeholders must be made, including that of the patients and relatives. Now let us go by organ systems. For patients who have neuro or psychiatric symptoms, we continue therapies for anxiety or depression. We follow standards such as maintenance of blood pressure to ensure brain perfusion and the use of quantitative neuromuscular depth of block. Neurologic symptoms could be due to part of the brain that shrunk the most, as shown by the red-yellow regions in the illustration. Preconditioning will help prevent perioperative occurrence of tachycardia syndrome and other manifestation of autonomic disruptions. Mechanisms of autonomic changes include damage to endothelial cells. Anesthesiologists must be vigilant of possible cardiac dysfunction in patients with prior SARS-CoV-2 infection. One must be prepared to use inotropes, vasopressors, antiarrhythmics intraoperatively. Covid-19 caused long-lasting pulmonary injury in patients who initially developed mild respiratory symptoms. Thus, one might consider CT scan or echo or PFTs preoperatively. Intraoperatively, one must be wary of events which may limit their reserves because they are susceptible to post-operative complications and might need ventilatory support. Renal biologic markers may be considered when evaluating patients. Thromboprophylaxis might be considered not only for those who have had COVID, but also for those who have been on quarantine. Patients who have had COVID may have post-operative pain that is difficult to manage, even if there are no neuropathies, which contraindicates regional anesthesia. Thus, pain history aside from our usual history and PE must be taken. We should take into account other considerations like state of anxiety and depression of patients and other medications that patients are taking. Exercise programs ideally must be in place, especially that even those who have never been infected with COVID have decreased mobility during the imposed community quarantines. These programs must take into consideration subclinical cardiac pathology post-infection, which might be observed even from competitive athletes, especially because these subclinical cardiac pathologies is not easy to differentiate from athletic cardiac remodeling. For the red flags and additional workups for athletes, may just refer you to the expert consensus statement. Registry for athletes who have had COVID may be in order. What are we now doing in response to the voluminous information available on hand? First, we begin with our pre-anesthesia evaluation form. Even if we are shifting to electronic medical records, we continue to review and update our medical records in paper form, such that we include in our questions the history of COVID and we write details in the corresponding space. Even if the research, which is the basis for consensus statements, have excluded the cardiac effects of vaccines, we still get the COVID vaccination history of our patients. We could use this data later on as we are still moving towards a changing landscape of the pandemic. We also include pain history and not just the current pain score of the patient. Next step, aside from pain history, is adoption of a frailty scale, which we could use in our pre-anesthetic risk evaluation and stratification clinics. We, including our Paris staff, can learn this. Training is available online for those who intend to use this. In the portion of functional status under risk stratification, wherein we write the different risk index, we now write the frailty scale, and this is not intended only for those who have had COVID. Requiring people to stay in their own homes for months with reduced levels of activity have an immense deconditioning effect on millions of people. Inactivity has a direct effect on mortality through its direct impact on long-term conditions. Surgical risks include major adverse cardiovascular events such as myocardial infarction, stroke, and all-cause mortality. According to Dr. Herbosa, this has been found even for those who are not hospitalized for COVID and could be leading to a new cardiovascular disease. Those able to enhance physical activity and health-related behaviors, known as preconditioning, may be able to improve risk. Thus, we include this in our pre-anesthesia instructions and education, especially if we see patients weeks before elective surgery. Aside from what we can all do at our small Paris clinic or during our tele-Paris consultation, we can hope to see pre-rehabilitation program geared towards patients who will undergo surgeries. The different departments and institutes of the hospital establish different programs for COVID patients, starting as early as 2020, but I'm not sure if program includes those who are still for elective surgeries, especially for those who have had reduced activities as they have increased risk regardless of age, race, and sex. Our department of anesthesiology is preparing itself to see more complex patient cohort even beyond the crisis of the pandemic. We're preparing to safely manage these residual effects by joining hands with all our partners. In summary, we look back at the COVID cases outside ORs attended to by our department. We presented the long-term effects of the pandemic. We move forward by presenting what we're doing and what we can do to confront the next possible global crisis, the new cohort of patients. To end, may I quote Dr. Herbosa during her lecture last Friday during the mid-year convention of the Philippine Society of Anesthesiologists. Most of the consequences of long-haul COVID may impact quality of life, affecting millions of people for a lifetime. And this translates to new cohort of patients. And Dr. Vergeer, DOH spokesperson, during the same convention said, "We need people in public service to address perennial problems of healthcare system. We are in a private center. We respond by sharing and transforming our great minds and passionate hearts into united, capable hands. And we look forward to more collaboration with different departments, institutes, and centers of St. Luke's. And we share this as we do today with our colleagues outside of the medical center. Thank you to all who joined us on very short notice.